Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Well, super excited today because I have Dr. Karima Oualla from Morocco coming on Healthcare Unfiltered Express. And Karima, it's your first time in the show, but you promised me it won't be your last.
Sure. Happy to be with you, Shadi.
And Karima speaks so many languages, but she is going to talk to us in English today because we don't have a lot of French or Spanish listeners, I guess. But when we do, when we go to the EU and become very popular there, we're going to do this in French. Karima, just because it's your first time, a little bit about what you do. You do GU oncology a little bit, and tell us about the setup of your practice before we get going on the topic that we're taping today.
Well, yeah, by my background, so I'm trained as a medical oncologist, and when you train for medical oncology in Morocco, so you are trained to do all solid tumors, so except hematology for sure. But then, so I was more interested and more focusing on GU cancers, thanks to my training, my fellowships also in outside Morocco. So I was deeply involved in GU and very interested in that field.
That's great. And you're working in a hospital setting, cancer center, private practice, your own, like what's your setup?
Yeah, I'm associate professor of medical oncology at my university in Fez, Morocco, and working in a university hospital. But here in Morocco, so I'm also allowed to have a private activity, so that I'm doing in parallel of my academic work.
That's wonderful. So we both were at ESMO 2025, and there are so many data that were presented from in GU oncology. And I've asked you to come on the show, and thank you for coming on to not really to go a lot over the science, although you're going to share with us a couple of exciting data, but more importantly, how do you take the information that was presented at ESMO and you go back to a country like Morocco, which is considered low middle income country compared to the US and Western Europe, and then you need to translate the scientific data, the information into reality on the ground, maybe in situation where you may not have access to all of these drugs. It's a very important topic. I haven't covered enough of this, but I think it should give us a little bit of an insight of the challenges that you may be facing. So let's start with some of, two or three exciting data that you saw in GU cancers, and then what are the challenges you're faced with in Morocco and any strategies to overcome these challenges?
Yes, you're totally right, Shadi, when talking about the all the advances that we have seen in last ESMO in Berlin. So every year, so we are having the results from clinical trials that are practice changing, and especially in GU cancers, in bladder cancer and prostate cancer, every meeting. So we had very impressive data and very impressive results of coming from phase 3 trials that are really practice changing. But as you mentioned, so those results are not easy to apply to use in clinical practice in all the parts of the world. So for example, when we take the example of bladder cancer, so for many decades, we did only have a systemic treatment, conventional cytotoxic chemotherapy, and this was something available in Morocco in all, I think, low-income countries, because it was mainly platinum-based chemotherapy, which is a treatment that is not costly, available. But then, so we had a complete shift to immunotherapy, targeted therapies, and more recently with the ADCs, we have seen the impressive results with AV-Pembro in first-line metastatic advanced disease in bladder cancer. That is, never seen before those results, and it's quickly the new standard of care for patients with metastatic bladder cancer. So when we come to reality for our patients in Morocco, so we don't have EV, enfortumab vedotin, available in Morocco till today. So we still don't have this drug available in Morocco, and not approved, not reimbursed. For the majority of patients who are having the general social insurance in Morocco, or the public insurance in Morocco. So also when we see now that this association was maybe will come a standard of care in neoadjuvant setting with the last trial presented in ESMO for the cisplatin ineligible patients, where we see that EV Pembro is moving also to the early setting. So it's showing again that EV Pembro is a very important association to have as therapy for our patients with bladder cancer in early setting, but also in advanced setting. With that,
Can I ask you just a quick question? You mentioned that it may not be available for the general people who have the general or public insurance, which means if somebody has a private insurance, that could be available for them?
yeah, this is one of the challenges here in Morocco, is that we have a discrepancy between the different health insurance that patient may have. So the one that covers the majority of patients or majority of population, let's say, so this social public insurance, it doesn't cover all the immunotherapies, all the ADCs, so in bladder cancer or in other indications. But we do have subset of patients that may have like private insurances that are covering more and more drugs, depending on the sector of work, depending on the income, etc. And for this subset of patients, yes, there is an exception that they may have access to some costly drugs like the immunotherapies, the ADCs, targeted therapies, etc. So for bladder cancer, so if we talk about the innovative drugs like IO ADC, so we do have available in Morocco pembrolizumab, atezolizumab, durvalumab, and very recently, so we will get also the avelumab as as maintenance for patients who received chemotherapy, not progression, under platinum-based chemotherapy. But even with having those drugs available in Morocco, it's also a matter of approval and reimbursement, and we may have those drugs approved but not reimbursed. So this is another level also of challenge. In terms of access, having access to those drugs.
Okay, so generally speaking, when you go to these meetings, you see all of these new drugs. Then when you come back and these drugs are not available, and patients probably have access to social media, chat GPT, and
ChatGPT, yeah.
right? And they say, well, how come I can't get this drug? How do you deal with this? And the second question is, I know you've been writing guidelines for GU malignancies for Morocco, and how do you really write these guidelines? You can't write guidelines that include drugs that you don't have access to in the country.
Yeah, this is very challenging, and I can say even frustrating because, as you mentioned, the patient now having access to internet, to chat GPT, they also know about all the new drugs, etc., and they want to have these drugs because they see that patients receiving those drugs are having better outcomes, and it's their right to have access to those drugs. But well, we simply explain how the access is difficult for some drugs, given that we still have to say that we are a limited resource country, and we cannot compare our economy, our healthcare system with the one in Western Europe or in North America. But we are trying to do our best as doctors from the scientific point of view, and also our role is to convince the health authorities like Ministry of Health and the authorities, the regulatory authorities that give the approvals, the reimbursement, etc. So when we write the guidelines, for example, for bladder cancer or prostate cancer or even for kidney
Yeah.
cancer, so from a scientific point of view, we cannot in 2025 state that in first line bladder cancer we give just platinum gemcitabine chemotherapy, because it's not what is the standard of care now. So from a scientific point of view, we cite all the standard of care, so independently of their availability. But so we do mention that there is like minimal requirements. So if you don't have access to Pembro AV, for example, so you may go for cisplatin, gemcitabine, nivolumab if patients can afford nivolumab and he is cisplatin eligible for sure, like in the checkmate 901. If not available, so we also discuss the maintenance with avelumab, especially that we will have it very soon for the patient who receive platinum-based chemotherapy and not progressing to go for maintenance. So we give like not priorities, but like minimal requirements, at least for the patients who cannot afford certain regimens. And we did the work with the IBCG, the International Bladder Cancer Group, so to make guidelines in Morocco that are adapted to our resources. And it was in collaboration with the IBCG. We are working on that. The IBCG already did that with for countries like Chile, I think, and Mexico, etc. So, and we are trying to have those guidelines that are adapted, mentioning all the the scientific advances, but also having like minimal requirements dependent on the access to what you have in your practice.
So one challenge is the availability of the drugs, and I think you're working on it, but I didn't realize that actually folks who have the private insurance have access to drug. I assume that drugs just simply not available in the country, no matter really what type of insurance you have. But it seems that that's not the case.
Yeah, so sometimes you can, the challenge is the drug is not at all available, but sometimes, so
It's
for some
available.
special cases with some private insurances, so they can afford this drug.
Right.
So even by shipping it from outside,
Got
etc.
it.
Well, it's a complicated situation.
Sure.
And it's not very frequent because the majority of patients, as I mentioned before, they are under the social public in
Yeah.
insurance.
Yeah.
One thing maybe that is also very challenging in oncology in general in Morocco, not only in GU, is this non-equity in terms of access to clinical trials that we see in the world. Because when we see the map of clinical trials in the globe, we see that more than 80% are located in North America and Western Europe, but also so there is, huge, activity of clinical trials in Asia, notably in China and Japan. But what about Morocco? What about North Africa and all Africa and Middle East?
Right.
First of all, because from, scientific point of view, as the Moroccan patient or the Moroccan citizen, so I would love to see if those results of those clinical trials are really representing my population. I see that the efficacy of certain drug A or B is good in bladder cancer, but when I see the population included, it's only US, European, for example, countries. So what about the African population? Is it really represented there? Would the therapy be so efficient, so good for the African population? We know that we are all different. I mean, from a point of genetic point of view, ethnicity, race, etc. So we may have some genomic differences. So already, so I think that the pharma companies need also to make an effort to include population from Africa, some other parts of the world that are very underrepresented in clinical trials. And also, we know all that having access to clinical trials is the best way to have access to those innovative drugs, because simply the patient doesn't pay for when he is included in clinical trial. And after the clinical trial, so there are some programs, access programs that also allow the continuation of treatment, etc. So I think if we can improve that also, the representativity of Africa, Morocco, and all other underrepresented countries in the clinical trials, it will be something very beneficial for patients.
Why do you think they're not opening clinical trials in Morocco? Is it infrastructure, or is it just the pharmaceutical companies or funding sources? They just forget that they're.
Mm, well, I don't know from industrial point of view what is happening, but we should also admit that I had an experience in clinical trials that were some clinical trials opened in Morocco, but they are very few, and we should say that also the legislation, the laws, the rules,
Yeah.
etc. in Morocco were somehow complicated at the beginning, but now they are more open. There are more facility to open clinical trials. I think we do have all what is needed to conduct clinical trials. So we have big centers,
Yeah.
multidisciplinary approaches, all the, from the point of view of material, so and the infrastructure. I think we do have all things needed to include patients in clinical trials.
Yeah. My last question to you, Karima, is more along the side of diagnostics and molecular stuff. I mean, when we were at ESMO 2025, there
Yeah.
were a lot of data that relied on NGS to make certain decisions. including in bladder cancer using ctDNA and things of that nature,
Yeah.
as well as there are essentially imaging studies and things like that for prostate cancer, as an example. Tell us what's going on in Morocco specifically, and maybe broadly in the Middle East when it comes to these novel diagnostics, whether it is on the molecular level or even on the imaging level.
Yeah, you're totally right. When it's about advances, it's not only about systemic treatments, but also all those diagnostic tools, starting with the diagnosis, pathology, molecular features, so etc. And I will not say that we are maybe at the same level of what is happening in high income countries, but in Morocco, for example, so we do have the next generation sequencing that is available in Morocco. We do also have, to be honest, the support of some pharma companies making it for free for patients. Like, for example, I will give the example of prostate cancer, about the HRD mutations, the BRCA, etc. So we can run for that for our cancer, prostate cancer patients without any problem. We see now in bladder cancer, for example, we are needing the ctDNA maybe to decide in the future about the adjuvant chemotherapy, immunotherapy, if it will be needed or not. It's possible to do that. So we have the needed platforms to do that. We have good platforms of pathology, of molecular biology, access to NGS, not everywhere, but in like university hospitals and big centers. So we do have all the tools to make good diagnosis, good characterization, dissection of the tumors at the molecular point of view, and also in terms of imaging. So we do have all the latest techniques in terms of imaging, including the metabolic imaging, like the PET CT, PET PCMA, etc. But so this is the contrast. So we are a country with very good infrastructures in terms of healthcare, but also the human factor is there. So we assume that we have good trainings for surgeons, for the therapists, for medical oncologists, for all the actors in the cancer care. But when it comes to systemic treatment, this is the major challenge, because we know that the cost is really high.
Do you see that changing in the next 5 years?
I think yes. I think yes, because economically Morocco is in a good way of development. So things are. I think if we are able to organize World Cup, so I think that we have enough enough. In incomes, or enough money to also invest in healthcare. So I think for the example of Morocco, so we are having a very good level of development in all sectors, in all fields. We need maybe more negotiations and more discussions with the healthcare authorities to give also much more priority to oncology in terms of having access to those costly drugs. Because at the end, as doctors, so our aim is to treat our patients in the best way possible, and we should have equity worldwide. So it doesn't make sense that a patient has access to efficient drugs, to good drugs in a part and not in another part. I know it's very philosophical, but we hope that we make the necessary efforts from the scientific community, but also from the authorities to improve the healthcare system in Morocco. And not only in Morocco, in all Africa and Middle East.
Thank you so much, Karima, and let's hope Morocco wins the World Cup next year.
We hope so. We just won the one of under
I
17 in
saw
Chile.
that.
So why not?
I saw that. Congratulations, and looking forward to having you on future podcast episodes.
Thank you so much. It was a pleasure to be with you in this podcast.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.